Thank you. I'm very pleased to be here, and thank you for inviting me. Um, so I want to tell you a bit about what happened in the UK, but just to explain the structure of the talk. So I'm going to talk about the quality and outcomes framework, and then the idea is we then break for questions. So it's not um, to give it just to mix it up a little. So please, if you're thinking about questions in the first half, please prepare them then. They won't all be at the end. And then I'm going to talk about quality measurement a bit more generally. I mean, healthcare is really complex, and so all of us have got room for improvement. Anyone who's, I work as a professional healthcare system, but I'm a user of healthcare system. My parents, my family, and so we all know that there's lots of things go wrong. There's lots of ways to improve. And if you want to improve quality, you can think of that in terms of, well, on average, we want quality to be higher, but we also want less variability. You don't want to be, well, on average, it's okay, but there are areas where it's terrible, areas where it's excellent. And I think really important, we don't have, I've got no answers for you. You can't easily take something that happens in one system and move it to another because there's a history to why things happen in systems. But certainly in the UK, there's been a real, we've had 25, 30 years of people saying things like, if you can't measure it, you can't manage it. So a real focus on measurement and the use of measures. So early 2000s, UK general practice is in crisis. So practice income has been falling continually for 10 or more years. Workload is going up. There's low morale, there's low recruitment. Older GPs are either cutting their hours or retiring early. And so there's a real consensus that something has to be done. There's something similar happening in specialist healthcare too. It's a system-wide problem, and so there's a commitment to increase the amount of money going into healthcare. And so the UK has always been below the OECD average in terms of percentage of GDP. The commitment was to raise it to average in OECD. So, but general practice in the UK is not part of the National Health Service. They're physician-owned businesses which contract to the NHS. So they provide all of NHS primary care, and almost all their work is NHS primary care, but they're in this slightly distant relationship. And so the government wasn't willing to just give money to GPs because they didn't trust the GPs to spend it on more care as opposed to more pay. And so the deal that was done was there'd be more money. This was new money. It would almost all be in pay for performance. So the government was essentially saying they were going to buy higher quality of care, and they didn't believe that care was any good at the moment. So they thought there was large room for improvement, and the GPs get increased money, increased funding out of it. And so pay performance is the mechanism by which both sides are meant to feel they're getting something. So what do you get? So biggest pay performance program in the world. The Brazilian one might be bigger. People argue about it, but about 20% of GP's income depended on pay for performance. And when it first started, there were about 146 indicators. So hundreds of indicators. There were a mix of things. There were structural indicators. You were paid for, organizing in a particular way. They were all gone within a few years. And the core of it was always quality indicators in multiple disease domains. And so some of these are process, some of these are intermediate outcomes, some of these are treatment. And so this is the kind of, this is what indicators look like. So process indicator, percentage of people with hypertension who have a blood pressure record in the last 9 months. The intermediate outcome that matches that is the percentage of patients with hypertension with controlled blood pressure. And if you don't measure it, you fail the outcome measure. Okay, so you've got an incentive to do the process in the outcome measure. What's meant by controlled blood pressure changes over time, tends to get tighter over time, gets more elaborated, and then there's treatment indicators. So if you've got coronary heart disease, potential patients prescribed an antithrombotic drug. So did it work? So the problem is that before they started it, there wasn't any central record of what quality of care was, and that's why government believed it was poor. So there's a few research studies which have got data from before QoF, and so this is one of them. And so what they're measuring is quality of care in 3 diseases. This is a composite of multiple indicators. So this is average performance across usually 10 or more indicators per domain. And it's measured in 1998 by people going into practices and looking at records. So it's a manual measurement of quality. And it's done the same way at each time point. And so this is when QOF happens in 2004, and coronary heart disease, probably nothing happens. It was getting better anyway. Diabetes and asthma, you get some improvement in quality, and then it stays flat. Now, does it stay flat because the incentives stop incentivizing you after a particular level, or does it flatten because actually you can never get to 100%? I can't make patients come in and see me. I can't always control their blood pressure. And so most of what's in this data is QOF indicators, but there are some non-incentivized indicators. But so there was probably some effect. You don't see a huge effect. And in some ways, what disappointed government is government kind of assumed that quality was down here and it was going to go up like a rocket, but it wasn't. It was already improving. If you look at things that are not incentivized, so things that aren't disease, so this is mostly measured by patient survey at each time point. So things like continuity of care, access to care, how well people rate communication with physicians. Probably nothing, I mean, nothing dramatic happens, although they probably all get slightly worse over time. Okay, another way of looking at this, so this is now measured in electronic health record data. So all UK general practices have used electronic records since mid-1990s probably. And so this is a range of measures, some of them in QOF, some of them not in QOF. So the blue one is QOF indicators, so it's already improving. It maybe improves a bit faster. It actually starts improving the year before we start getting paid, because we all know what's coming and we all start preparing for it, and then it flattens off. The light purple line is incentivized prescribing, and again, you see a small increase. The dark brown line is non-incentivized prescribing measures. They don't change. And these are other non-incentivized quality measures, and they probably flatten off. So the interpretation of this is, yes, you get a bump in what you're paying for, but you make things worse for things you're not paying for. So if you make me focus on something, I've only got so much time in the world, then I'm not focusing on something else. And so whatever you focus on, you may pay a price in something that you're not focusing on. So the other question, well, did QOF reduce inequalities in care? And so this is all QOF indicators, and it's all after we start paying incentives. So this is year one of the QOF on the left, year 2, year 3. And this is the distribution of average quality by practice, where the red one is the richest fifth of practices, or practices serving the richest fifth of patients, and the blue one is practices serving the poorest fifth of patients. And at the start, then on average, practices serving poor people did worse, and there was more variation. And over time, actually, it flattens out. So some of the improvement you see in QOF is probably practices serving the poorest people catching up. So they have a harder job, because people who are poor, people who have got alcohol problems, are much harder to get into care than people who are affluent, people who are adherent to care. So there was some evidence that QOF reduced inequalities, so that's all good. But then you've got to think, whatever you do, you've got to worry about what's going to go wrong as a result. It's very easy to focus on what you intend to happen, but unintended matters. And so I've got 3 examples of these, and so these are all quite complicated. You could ask me about them if I don't explain them well. So in the diabetes register, we started out with just diabetes, because the indicators were the same, whether you had type 1 or type 2. And there was a lot of pressure from the diabetes specialists that we had to define type 1 and type 2 separately. And so that's what they did. They changed the register to say that you were only on the register if you had a code for type 1 or type 2. But the problem was that there were people on the register who just had diabetes not otherwise specified. It didn't say. And when they changed the register, they didn't give us any incentive to improve the register, and so people got lost. They fell off the register because it didn't say type 1, type 2, it just said diabetes. And if you had secondary diabetes, because you'd had pancreatitis, was that type 1, type 2? And so these people fell off the register, and actually their care got worse. So you improve the quality of the register, but you make care worse for some people. And so that was fixed, but it Wasn't great. There was a real desire to do something beyond the usual suspects. So most of the diseases being incentivized were physical disease, lots of cardiovascular disease, not much mental health, hard to define quality indicators. Really real strong desire to make mental health just as important, and so to create measures. And what was introduced after a few years was incentivized case finding in people with chronic disease. So if someone had coronary heart disease, they were meant to be screened with PHQ-2, and if that was positive, they were then meant to get an assessment. And if you were diagnosing someone with depression, you were meant to use a structured score at diagnosis and after 6 weeks. And so it was meant to improve quality of depression care, but it was just dropped in. There was no real attempt to persuade clinicians that this mattered. Clinicians, many of them were unpersuaded by that. And it was therefore done in a very tick box way. The person with coronary heart disease was given a 2-question screen by the receptionist, the admin person at the clinic. They would tick the boxes, the receptionist would file it. So it's done, you get paid for it, but was it used? Not really, because there wasn't enough attention paid to persuading people, what are you meant to do with this? What's the purpose of it? Why does it matter? Where's the evidence that it's effective? And the third one was, there's a payment system attached to this, which I haven't tried to explain because it's really complicated. And when they were negotiating the contract, there were lots of people saying, well, if you did this kind of practice is going to suffer, you're going to penalize this group. And so there was a last-minute fix, which was to protect practices who didn't have very many patients with chronic disease. And when they fixed it, they broke the payment system. And what that meant was that at the extremes, there was really large variation in payment, which penalized small practices and practices serving poor people. And so as an example, in Scotland, in the first year, there's 2 practices. They both have 30 people with coronary heart disease. They both achieve exactly the same level of quality. One practice is small, rural, 560 patients. It gets paid 600 euros. The other practice is a very large student health practice. No one's got any chronic disease. They get paid 30,000 euros because they broke the payment system. And so last-minute fixes to complex systems without really testing them hard, not a good idea. Okay, so the next problem is you're paying for quality, but you can't keep paying forever. So if you're paying for quality and actually, 95% of people with high blood pressure are having their blood pressure measured, do you want to keep paying for it year after year? And if you want to bring in new indicators, you have to get rid of old indicators. And so, what happens when you stop paying? So this is this is English data. So as indicators are being removed, they carried on collecting the measure. And so you can now, what you're looking at here on the left is 3 intermediate outcome measures where they took away the incentives. They kind of thought, it's not really going to get any better. And so the top one is cholesterol control in patients with coronary heart disease. The blue one is cholesterol control in patients with stroke. And the green one is patients with epilepsy who are documented as being seizure-free in the last year. And the red line is where you take away the incentives. And so you see the cholesterol ones get worse. These are similar indicators which are still incentivized. They don't change at all. So this is the effective incentive removal. And so when you look at that, you think, well, that's not so good. Cholesterol control's got worse. But actually, that's all driven by us just not measuring cholesterol in these people anymore. So if you don't measure it, you fail the outcome measure. And do you really need to measure cholesterol in people with CHD every year? You had a heart attack 6 years ago. You've been on a atorvastatin 40 milligrams ever since. Your cholesterol's always been 4. Do you really need to measure it every year? And so actually quite a lot of quality indicators don't make sense if you say you've got to do this every year for the rest of your life. And so actually sometimes we just stop measuring it. And who cares? If you're on the statin, you get the benefit, actually. The epilepsy one is slightly more complicated. So coronary heart disease, diabetes, they're all being looked after with a register, a recall system, and they're called to a review. Epilepsy was always done more on the fly. Towards the end of the year, if you hadn't already seen them, you would ring them up and do a review or get them in to do a review. But because it wasn't so organized, when they removed the epilepsy indicators, all the care maybe just disappears because it's not kind of built in, it's not habit, whereas coronary heart disease remains habit. And so you see this with all the incentive removal, you see that things get worse. But it's probably a bit more complicated than that. So this is not in QOF. This is in a different bit of pay performance, but it's similar measures, similar deals. So this is screening for alcohol misuse. And so the grey bit is the period where they're incentivizing it. So we have a period before incentivization where we're doing more screening for alcohol misuse. So this is using structured screening tool. When you turn on the incentive, either nothing happens or it stops improving so quickly. So down at this end, this is persuasion, guidelines, people saying it's a good idea, lots of local initiatives. This is national pay for performance. And when we turn the incentive off, it falls off a cliff. And you actually end up in a worse state than you were at the beginning. And this is probably a shift from internal motivation. What's the right thing to do? What should we be doing? What's good care? You're now externally motivated. You're doing it because you're being paid. You take away the external motivation, but you've also destroyed the internal motivation. So people now think, oh, well, it's only worth doing if you're paid for it. Well, I'm not being paid for it. I'm not going to do it. Whereas back here, they were thinking, well, it's worth doing, and therefore I'm going to do something. And so this is one of the fears about pay for performance, is that actually it might work, although it doesn't work in this case, it might work, but actually what are you doing to people's motivation to do a good job? I'll only do it if you pay me, is the risk of what you're saying. So over time, QOF has changed a great deal. So the initial indicators were 3 people in a room sitting down and making up indicators based on national guidance. Mostly physical, pretty strongly evidence-based, but a lot of this was things that we already knew we ought to be doing. It was already well accepted. And there was loads of support in the first year to get this going. IT support, setting up searches, templates for data entry, guidance about why these indicators mattered. In the first few years after that, then it became rather more special interest groups. People would say, oh, well, we've got to get our condition into QOF. And often the indicators they were proposing weren't accepted or weren't in use. That, depression would be an example. And actually some of them were really badly evidence-based. They were just people's pet. People just thought, oh, we've really got to screen for nut allergy in people with asthma. Wow, do you really? And then in the third phase, it became much more structured. It's the National Institute for Health and Care Excellence, who are the national guideline developer, so very strongly evidence-based. But actually, it's also narrower, because if there wasn't really strict evidence, they wouldn't do a measure, and that then constrains you to places where there are evidence. And you just have problems with evidence where, what do you do about multiple conditions? Well, there's no evidence for multiple conditions. So this is a systematic review. This is looking at, so it's 305 trials where someone has looked at what proportion of people with a condition would be excluded from this trial. And so it runs from 98% down to about, one trial where it's 0%. But, headline message, so a quarter of trials exclude 90% of people, half of trials exclude 3/4 of people, 3/4 of trials exclude half of people. So most people with a condition are not in the trial that determines their treatment. And who gets excluded? Well, you won't be surprised. It's old people, sick people, people on lots of drugs. So what does that mean for, where is your evidence base? And so if you're thinking about kind of how fit people are, very fit people, very frail people, at one end, we've got people who die of disease, and precision care is what we measure in quality indicators. Have you got high blood pressure? Is your blood pressure controlled? And at this end, you've got people who don't die of disease. They just die. And if you're not going to die of disease 1 today, you're going to die of disease 2 tomorrow. And this is a very different kind of precision, but the risk in pay performance, one of the objections to it was that effectively we take this kind of precision, we apply it to this kind of person, and people over here are all taking 15 drugs, and they were never in the trial. No one in a nursing home was ever in a drug trial, pretty much. So, you ought to worry about some of these broader issues. So what did QoF do? I mean, it did give some improvement in quality. There's at least some negative effects. It's not a magic bullet. People thought it was going to be a magic bullet. You just fire pay performance and everything will be perfect. Not true. It doesn't win hearts and minds. If you want to win hearts and minds, you have to persuade people. You can't just pay them. There was no planned evaluation of it. So all the evaluation happens by researchers doing it some years afterwards. And if you're going to evaluate it, you really need to think about, not just the intended, what do you expect to happen, it's all the unintended. You ought to test that to destruction. And it's quite easy to do. You just get a bunch of people who are being paid to sit down and think about all the ways that the system could go wrong. And they will very rapidly come up with 10 ways to break the system. Because it's easy when you think about it, but you have to think about it. And then the other thing that happened in the UK was that within the 4 UK countries, you get real divergence you get increasing divergence in healthcare. So we all have an NHS, but they're not quite the same. And in particular, England's much more interested in markets. England's more centralised, much more central direction about what local areas should be doing. And so in particular, Scotland abolished QoF because everyone had fallen out with love with it. England is moving in that direction, but remains more interested in market mechanisms and payment systems. And so in Scotland, we moved to a system where instead of paying people for quality, you paid people to participate in cluster meetings. So clusters of 8 to 10 practices getting together to talk about what they think is a problem and talking about how they might fix it. So a very different system. The money all disappeared. So within 10 years, practice income is back to where it was in 2003. So there's been a further crisis, there's been further increase in money in general practice. And so the current version, again, they don't just give the money to the GPs, but what they're doing is they're paying for additional staff in general practice. So physios, extra nurses, mental health workers, link workers, pharmacists. And so that's what we currently do in Scotland. Okay, I'll stop there if there's any questions.
Thank you very much for a very interesting presentation. My name is Matti Reinikainen. I'm an anesthesiologist, intensivist from Eastern Finland. Being seizure-free, obviously, is an important patient-centered outcome for a patient with epilepsy. Now we saw that during just 1 year, the proportion of patients documented being seizure-free went down from 60% to 10%. Yeah. And most probably, there was no change in quality of care. Yeah. So our understanding of the quality of care is often dependent on what is documented in the registry, and that may be very problematic.
Yeah, and so actually some of the gain. I mean, I was saying when you take the incentive away, some of the reduction you see is probably just change the documentation, but the same is true at the start. Some of the improvement you see is almost certainly just changes in documentation. So when I measure someone's blood pressure, I can write it in free text or I can enter it as a number. The quality indicator only picks up the number. So yes, I don't think quality of epilepsy care changed. I don't think the QoF indicator actually improved it very much either. And one of the issues of QoF is you're paying GPs for doing something. If you really want to improve epilepsy care, you need an improvement program which includes both general practice and specialist care. And one of the problems in the UK is the neurologists never really owned epilepsy. So they would look after the people they saw, but they would discharge most people with epilepsy who weren't very complicated, and they didn't see it as really as their responsibility to worry about those people. And a feature of diabetes, for example, would be that in the late 1990s, diabetologists kind of took responsibility for everyone with diabetes, not just the 10 or 15% of people that they saw, and therefore reached out into the community to say, we all need to do something better. And so QoF, one of its weaknesses, it's not system-wide. And if you really want to make epilepsy care better, you need the whole system.
Antti Malmivaara from this institute. Thank you very much for having a break for questions. I really appreciate it. You had this socioeconomic status, was it individual data? And if it was individual data, did you have problems with confidentiality of that kind of sensitiveness of that kind of data, both in obtaining the data and from the public afterwards? Thank you.
So the way QOF works is that we all have our own individual electronic record. The payment system is driven off an aggregate reporting system, which sits alongside the electronic record. And so we don't have to hand enter any data, providing we enter it in the record in the right way, it comes out as an aggregate at practice level. So at practice level, all that is known nationally for QOF was there were 58 people on the register, 36 of them had their blood pressure measured. The socioeconomic status is not measured at individual level. We don't have that in the UK except at census. It's based on a small area measurement. So it's people living in the fifth of the most deprived areas, but it's at practice level. So it's practices who on average serve the fifth of and so it's not a precise socioeconomic measure. If you do it at individual level, the differences are almost certainly larger because, of course, area-based measures average things out. So that's how we measure it. So there isn't a confidentiality issue in that, but it's not a very good measure.
Bruce, we also have a question from our online audience, if that's okay. So looking at graphs about starting initiatives, the promise of the upcoming carrot or the apprehension for the foreseen stick are more effective than the actual carrots or sticks themselves.
Yes, so QOF was partly designed based on something that was run in one region. And in that region, the cost of doing it to general practice was more than the financial incentive, but they all did it. So in fact, the offer of money in the pre-runner to QOF was enough to motivate people to do something that actually cost them money because it was better care. And so at least some of the way that pay performance works is effectively a carrot where it's reciprocity. Someone gives you something, you have to give them something back. And the money is recognizing that GP's time matters, that the work they're doing matters. So it's not all about pure financial considerations. Carrots and sticks, so QOF was only carrots. If you didn't do the work, you didn't get paid, but if you did the work, you did get paid. In the US, they're much keener on sticks. So in other words, if you don't do it, you get financially penalized. And they're much keener on tournaments. So within their pay performance in the US, there's often so much money available, and the people who do best get all the money, the people in the middle get nothing, and the people at the bottom get penalized.
From your point of view, which ones are more effective? Carrots or sticks?
I have no idea. So, I mean, the data on pay performance shows that at best you get small effects. It's a bit inconsistent. There's been a few trials. They sometimes work, sometimes doesn't. In general, though, I think if you're relying on professionals to do the right thing for all the things that you can't measure. And so if you're beating them with a stick all the time about things you can't measure, you are almost certainly damaging their internal motivation. If you want to, if you continually beat me over the head with a stick, then I will become sullen and uncooperative. So in general, I think sticks are probably a bad idea because you must harness internal motivation for all the things that you can't measure. So I can run a perfect system which delivers all these quality measures, and I run it like a sausage factory, where the person is just, they're just a piece of material that passes through my medical factory and I spit them out the other end. I care nothing about the quality of their experience. Is that good care? Probably not. So the evidence, I've no idea. But I think sticks are generally inappropriate, except at the extremes. There are doctors and other clinicians who deserve to be struck off. Okay, but there's a very small number of them. And if you design the system to beat everyone up, you're almost certainly damaging it.
We do have some other online questions as well, but would you like to take them at the end of the presentation or?
Should we move on? So
Yeah, I think that's a good idea.
Okay.
Yeah.
Okay, so quality measurement more generally. So, remember, if you can't measure it, you can't management. This is about measurement. What kind of questions might you ask? Well, what do you intend to do with measurement? Measurement is not an end in itself. It doesn't do anything, measuring on its own. Who are you aiming your measurement at? What are you going to measure? What are you not measuring? And then what about unintended consequences? And so I'm going to talk about that a little bit in general. Then I'm going to show you some research examples, which are my choices when I'm doing research studies in this thing. So you've kind of got a spectrum of how you're going to use measurement. So you've got high trust, high stakes. You could think about this relies on internal motivation. This believes in external motivation. So high stakes means the person being measured, it could all go horribly wrong for them in some way. And so what does that look like in terms of quality improvement? Well, traditionally, we just leave it to professionals. And actually, there's loads of care where you just have to leave it to the professionals because you can't measure it. You can't easily measure what's right in a frail older person where you're stopping all the drugs against guidelines. They've got 3 conditions, they're on 6 drugs. You stop them all because they're wrong, but the guideline says you should be doing them. So you always have this in your system. You then have kind of persuasion guidelines, national service frameworks, breakthrough collaboratives, PDSA cycles. It gets a bit harder as peer comparison. So showing people how they're doing against other professionals, you're relying on kind of professional reputation. If you public reports, you get public reputation as well. So in the first year of QOF, every local newspaper in the UK ran a front page article called "The Worst Practice in," wherever you happen to be. But only once. It was boring. It wasn't interesting year after year. But that was important for us early on. All this data was public. You can pay for performance in various ways. And then you can kind of really sanction performance. You can remove people from the medical register. You can sack managers. You can do all sorts of things at that end. And in reality, our healthcare systems are really complex. It's always a blend because there's always a mishmash of things introduced at different times. And so it's not always a very well-designed blend. And it's not always a choice. If you can't measure it, you're definitely down at this end. If you can measure it, you can choose something in the middle. So come back to this. So, did QOF work? So this paper, it's in the New England Journal of Medicine, and people are interested in this. But actually, it's much more interesting what happens here. Quality was improving. Well, why was it improving? We weren't paying for it. And it was improving because of the national guidelines were invented in the 1990s, systematic, large-scale national clinical guidelines. Evidence-based medicine was changing the culture of medicine. National service frameworks were governments saying, we've got to do something about cancer, we've got to do something about, so national initiatives with investment. And then there's also lots of local things going on. A local area says, we've got a real problem with alcohol, let's do something about it. And so I say, you can get over-focused on what happened in paid performance. Much more interesting is just how do you improve quality? So who are you going to measure? And so actually some indicators just don't work at practice level. There's not enough patients. And so epilepsy, for example, is at the margins of what you can do at practice level in the UK because the number of patients is quite small. And if you're in a small rural practice, you might only have 3 people with epilepsy. Well, what does a measure mean in that situation? And so typically, if you're trying to target small areas, you can only really go for common indicators, common conditions. And you can't look at inequalities at small level because inequalities happen between practices because practices serve a poor community or a rich community. Are you thinking of targeting, municipalities, regions, hospitals, primary care practices? And in some ways you have to target them all, but if you were going to go for carrots and sticks, you could argue the best place to apply a carrot or stick is higher up, a big organization that can take it. And the higher up level then has to think, how's it going to change clinical practice lower down? And you might choose a different blend in that. And so, there's no evidence for this, but I've always thought that, your intervention mechanism should depend on the level that you're trying to target. And I'm not in favour of sticks, but sticks for small practices almost certainly does you bad, because some people are going to get sick of it and just retire early, and then you no longer have a service. So what are you going to measure? I mean, some areas are just much easier to measure than others. So these are some of the Finnish quality registers. Diabetes is easy. There's loads of measures. Psychosis, much harder. Psychosis in primary care, really hard. So in the UK, all of the psychosis measured in primary care were nothing to do with psychosis. They were all to do with cardiovascular disease, because that's what people with psychosis die of. And in the UK, they die 10 to 20 years earlier than anyone else. And GPs actually don't really do the psychosis care. But psychiatrists definitely do not do cardiovascular care. And so, okay, the assumption was psychiatry would take care of the psychosis, but only the primary care system could take care of cardiovascular risk. And so you also need to just, how do overlaps work? You've got separate registers, but many of these people will be in multiple registers. So how do you make that work? And so sometimes it may not matter too much. So cardiovascular disease, diabetes, it's all kind of the same. All the cardiovascular risk is taken care of in the diabetes care. But what you don't want is for someone to have to go to a diabetes clinic and then 3 weeks later go to a cardiovascular disease clinic. Well, it's the same care. So there's a coordination issue. But you do need to worry about the discordant overlaps. If you're running psychosis quality, then what are you doing about cardiovascular disease? And it might not be in your register data because that's all about the psychosis. But that's not why they're dying 10 or 20 years earlier. And then you get the big problem, but what do you do about care that is not condition focused? What do you do about continuity and coordination? What do you do about patient experience? What do you do about multimorbidity and polypharmacy? And we've never solved any of that. So I have no idea how you do that, but it's very hard. And if you just focus on this, well, what's happening with all of this? And so you need some kind of other mechanism. And so there's just issues about interactions between registries, but you've also got to think about, the wider system, because there are other bits of the system trying to think about these other things. Well, how do registries interact with that would be a question. And what do you about unintended consequences? So no matter what you do when you start measuring, you risk tunnel vision and crowding out. Okay, the measure makes something visible, and therefore you stop seeing stuff in the periphery, and you crowd out things in the periphery. The focus of all activity becomes what you can see in front of you. And so this is a quote often ascribed to Albert Einstein, but I think that's almost certainly made up. Not everything that counts can be counted, and not everything that can be counted counts. So how do you deal with the things that you can't count? You need to worry about inequalities. So on average, any richer area, practice serving richer people, will do better than a practice serving poorer people, because it's easier to deliver care. And so even if you're just public reporting, you run the risk that you effectively reward services and doctors and nurses who look after rich people. And in pay performance, you may pay them more. Is that a good thing? Is that what you want your system to do? Or do you actually want to focus on the poor? And the poor, the sick, the disabled, the alcoholic, the drug user, the person with serious mental illness, who mostly lives in poor areas, or is much more likely to live in poor areas. You may also, it's much easier to measure in the disease area, so you're kind of, again, strengthening specialism over generalism, but we have aging populations. The future is not single diseases. The future is people with multiple diseases and polypharmacy. And really importantly, whatever you're doing, you just need to think what can go wrong. And actually, when you're designing these things, and this happens to me, it's quite hard to think about what goes wrong. Just go and ask your colleagues on the clinical side and say, what would go wrong with this? And they will immediately come up with 7 things that can go wrong. So some UK examples from research. So these are all research studies, but this is me thinking about how did I make these decisions? Okay, so the first one's a trial called EFIPS. This is a feedback trial. And so the target is general practices. That's who we're targeting. The indicators are all high-risk prescribing, and we chose those because they weren't QOF and because I was interested in prescribing. So it's my hobby horse. It's done in 262 general practices. We don't consent the practices. We just send them stuff and they do what they want with it. And we could do that because the NHS is always sending practices stuff. Every day someone emails me some guidance or whatever. So the usual care arm is actually enhanced usual care. So this is another reason we didn't need to consent practices. So they get some written education about this prescribing, and we make it easy for them to find the patients. We give them a search so that they can find these patients in their practice. And if you don't make it easy to find patients, you shouldn't be surprised that many practices don't do it. If something is hard to do, you're less likely to do it. The second arm is they get feedback and they're benchmarked against. So if you ranked 100 practices where 1 is best and 100 is worse, the benchmark is 25. So we're effectively saying that 3/4 of practices are below benchmarks. You're giving them a stretching benchmark because we think this is improvable. And then arm 3 gets all of that and a behavioural change intervention in writing. So what happens in that? Well, so this is the period before the intervention, the straight line's the intervention, and basically they're not quite the same at baseline, even though we did attempt, well, they're actually the same at the point of randomization, but they're not quite the same historically. But over time, the 2 intervention arms, you end up about 10% better off than if you hadn't done the intervention. But this is a really cheap intervention. You just build the indicators in national data, you press a button, it generates 262 reports, you press another button, it emails them to the practices. And so 10% is actually pretty good for an intervention that is very cheap. But can you do it better if you do anything more complicated? So this is now, same thing, so it's targeting general practices, it's 9 high-risk prescribing indicators, and these ones are all about non-steroidal anti-inflammatory drugs and antiplatelet drugs. It's complex, they're volunteer practices. The design is a stepped wedge randomized controlled design. So they all get the intervention, and this is what the trial looks like. So we measure the outcome every 8 weeks. We have a period where none of them are getting the intervention, and then they're randomized in groups to start at 8-week intervals. And so you have a shift from no one has the intervention to people getting the intervention. We turn the intervention off after 48 weeks, and then we measure what happens afterwards. And so randomization to time means that everyone gets the intervention. So that helps with ethics committees who don't like you not doing something if it's high-risk prescribing. And what was the intervention? Well, they get education, which is both written. So we know that written education doesn't work. If you just send someone a piece of paper saying, this is what you should do, it makes no difference. Endless trials of that. But they also get in-person education. So they get a visit by a pharmacist to talk about prescribing. And we know that on average that does work. We pay them to review patients. So we don't pay them to change the prescribing. We pay them to look at the patient and make their own mind up. Because we don't know if this prescribing is right or wrong. It might be high risk, but it's right in some people. We give them an informatics tool to support review, so to identify patients and support review. So the information you need to do the review is in 5 or 6 different places of the record. And so the informatics tool brings it all together into one screen, and they then get comparative feedback of how they're doing compared to the other people in their group. How many patients have they reviewed? What's their rate of prescribing? Has it changed? How does it compare to other people? So does that work? So this is calendar time. This is trial time. So 0 is the point at which practices start the intervention. So this is the pre-intervention period. You turn on the intervention, you get a change, you turn off the intervention, and it stays. And that's quite important because people hardly ever measure that. And so you spend a lot of money on this intervention. If it all just goes back to baseline, it's a waste of money. But that's rarely measured. So what happens? So you get about a 1/3 reduction in the targeted prescribing, and that's about as good as it gets. There's not that many trials in this field. That's as good as it gets. We're asking them to review people who had the prescribing, and so these people get a larger decrease. But really importantly, they change their future practice. So if you don't change who you're starting on these drugs, you just end up back at square one. But they reduce the high-risk prescribing, and then there's a bunch of admissions associated with this kind of prescribing, and they go down. So you do see an effect on hospital admission with bleeding, with heart failure. And then acute kidney injury isn't significant, but it does go down. And then other kinds of admissions don't change. So it does look like it's an intervention effect. So that's all lovely. does it work in real life? So in a trial, you're always giving people more support than you're ever going to give them in real life. And so one of the health boards in Scotland, Forth Valley, really liked this, and they thought they would do something similar. And so they already had a quality improvement program where they pay practices to participate in the program, and every year they do something different. And so one of their topics in one they decided was going to be 3 of these high-risk prescribing indicators. And so this is what's happening to the indicator before you turn on the intervention. The first line is when they start their year of intervention. The second line is when they turn it off. And you get something that looks rather similar to the trial, which is prescribing is already going down. If you think it's dangerous, it's already declining, is the general rule. They get a bigger reduction than we got in the trial. You do it in real life, it's better than the research. That's not common either. And then you turn it off and you go back to the baseline decline. So fantastic. So they liked it so much that next year they decided to do it again. So this is the same practices, the same intervention, different measure, and absolutely nothing happens. Nothing at all. So the triple whammy is non-steroidal anti-inflammatory prescribing in people taking an ACE inhibitor and a diuretic. So it's got acute kidney injury risk. Antipsychotics and dementia, just way harder to change. These drugs are almost always started by specialists who never follow the patient up. But the GP is prescribing. Who owns the prescribing? Non-steroidals, we own it. It's pretty straightforward. Unintended consequences. Okay, so we've got rid of some non-steroidals, but look at our opiate prescribing, which in the UK is going up in a straight line. So are we better off getting rid of non-steroidals and having opiates? I don't know. So we know this prescribing is pretty risky and causes hospital admission. But on the other hand, is opiate prescribing better? On the other hand, what's the most dangerous thing that I ever do in general practice? It's that. Okay, the UK the estimate in the UK around the time this trial was done was that this killed about 2,000 people a year and caused about 2,000 major strokes. If they weren't demented, it would be illegal. But somehow we tolerate it, despite the fact that there is very little evidence that this has a big effect. Good evidence of small effect, but absolutely nothing happens. Why? Well, I mean, there's no magic bullets. There's no intervention you can do that is guaranteed to work. Context really matters. And so if you think about antipsychotics, how persuaded are clinicians by the indicator? Really critical. Who owns it is a real issue. Who owns this problem? And antipsychotics and dementia, there's a real ambiguity about who owns it. Is it the specialist? Is it the GP? It should be both. With antipsychotics, there's real fear about the adverse consequences of stopping. If you stop the antipsychotics, someone might become much more behaviourally disturbed, end up in residential care. So there's actually not much evidence for that, but that's the fear. And so this isn't really a technical problem. This is a professional culture problem. We all struggle with stopping drugs. So in medical school, I spent years being taught how to start drugs, and I had about 2 days of being taught how to stop drugs by a geriatrician. No one teaches how to do it. Okay, so just to conclude, so if you can't measure it, you can't manage it. Endlessly quoted. I've sat in so many meetings in Scotland where someone has said that. Is that what Walter Deeming really thought? So Walter Deeming is the father of statistical process control. So this is, from the US, ignored in his own land, but this is where this is how Toyota build cars. Did he say that? He did say that, but this is not the whole quote. So this is the whole quote. It's wrong to suppose that if you can't measure it, you can't manage it. A costly myth. And so measurement is great. I really like measurement, but you've got to be really careful. It's not the be-all and end-all of life, because most of healthcare isn't measurable. And you really need to worry about what you're not measuring. Thank you.
Professor Guthrie, thank you so much for a great presentation, great keynote. And now we have a couple of minutes for a little Q&A, if that's okay. And we'll get a first question from over there. Yes, please.
Thank you. A fantastic presentation. I'm Jana Suvisaari, and I'm representing the Psychosis Quality of Care Register. And we are going to collaborate with Diabetes Care Register. So we are interested in that part. But my question was about, what do you think about PROMs? And especially, I read that that there is an initiative, of course, in psychiatric care to use proms in every visit in England. So do you think that is feasible?
So in Scotland, we have a national patient survey run by government, which which contacts a sample of patients and gets them to fill in a patient experience measure. So a PREM, not a PROM. But you can argue patient experience is actually an outcome. You know, if you're a high user of healthcare, experience really matters. If you go to 30 appointments a year, it really matters. And so that's as far as we go in Scotland. In England, they had an ambition to do proms in all sorts of things. And they introduced the first set in 2009, which was for hip and knee surgery. And they never extended it because it's really expensive. The idea that you do a prom every time you consult, yeah, if you were going to the GP 15 times a year, every time you went, you were asked to fill in a survey. You know this in your normal life. You buy a mug online, and someone wants you to do a review of it. It's that in reality, I honestly don't think you'll find that. I think lots of patients just won't do it. They just want, they just want to go out the door. So the routine collection, proms are a really fantastic idea, but the routine collection of them, I just don't know how you do it, and it would be quite expensive to do. And if you made it dependent on me, where I get penalised in some way if I don't measure a prom in half the people coming through my door, then I have to have an admin person standing at the door not letting people out, and that costs money, and that's not good. So I don't know. A lot of the proms are not very sensitive to change. So do you really know you're doing better? A lot of the proms are socially patterned. Poor people have got worse quality of life than rich people. And so, again, you risk rewarding the rich compared to the poor. Or you risk rewarding professionals who serve rich people rather than professionals who serve poor people. So it's a really good idea, but it's one of those things I would say, well, you would never want to introduce that as a national system. You would want to try it out and really work out what its value is, how you might use it, and all of its unintended consequences, would be my feeling.
Thank you for a great question. Let's see if we can squeeze in one or two more questions. One's from the front row here. Please.
Thank you, Bruce. Very, very interesting presentation. I'm Aapo Tahkola from National Quality Register coordinating team. I have one comment and one question. First, the comment. I think your message with the importance of who owns the measure, who owns the goal, is very important for us working in national indicators. Then the question, if I got you right, you mentioned that one big problem with COF indicators was the thing that their definitions of the measures were many times too tight or even a little bit silly, so that they didn't leave you place to be innovative and find your own way to get good quality, but they made you do something every year, even if you thought it was silly. So have you any comment on that?
Yes. So you might have an area where actually alcohol is more important than. No, I can't. I mean, the problem is when you think of things, you then have to say something's not important. I don't mean that, but relatively, one thing is more important than another. In this area, we have a real issue with. So where my practice is in an area with there's lots of supported housing. So it doesn't have many old people, because actually the people who live nearby all die early. It's got loads of serious mental illness. My old practice was a former mining town, very large numbers of old people, lots of cardiovascular and respiratory disease. And so a one-size-fits-all may not be quite right for those two practices. But I don't have an answer to that. It's just it's a tension. In some ways, it's good to measure at national level. You get comparative data, and if you make it all too local, then there's no easy way to compare. So some things must be important enough to do nationally, but you do want local flexibility for us, what matters today is this. But all my effort is on something else. It's not ideal.
Our time is up, but let me just, I don't want to ignore our online audience, so I'll just get one question from them. Great lecture, Bruce, fine examples. Could you give some prerequisites for getting useful information from QOF approaches? For example, useful objectives, good recording, good data, useful analysis, any others?
I think in Scotland, we got rid of QOF, but we also threw away measurement as a result. And so we're now in a situation where there is very little, well, there's limited routine measurement of primary care quality. And so actually a key lesson from QOF is it's pay for performance, but the two are not, the two aren't linked. You can do the quality measure, you can do quality measurement without paying for it. And in the UK over 20 years, we've kind of come to think of them as being the same thing in primary care, and they're not. And actually measurement is, measurement is good, but you just need to lift your eyes from the measure and think about all the things that you're not measuring. So QOF never measured more than about 15% of primary care activity. 85% is unmeasured.